A little bit, Jackie. Up. Yeah, that's much better. Thank you. Okay, so, all right, you can start.
Can you put that slide?
Sure. I want to share my screen. Can you see it?
Presentation mode? Yeah. Yes. Okay. Good afternoon, good night, and good morning for some of you. É um prazer para mim estar recebendo vocês e todos os participantes.
It's a huge pleasure for me to welcome you, all the participants, all the panelists to this event. It's highly important for PAHO and for our listeners. I am Maristela Monteiro, and I am the main assistant for alcoholism at PAHO in Washington, D.C. And I will be the moderator for the session today. We are currently waiting for some people to join us, but in the meanwhile, you can take a look and see how you may use Zoom. Basically, there is interpretation in English, Spanish, and Portuguese. All you need to do is to choose the language you prefer by clicking on the globe at the bottom of your screen where you see the word interpretation. Any question may be asked during our Q&A session, and you can also write it down on the chat, but we would rather that you ask your questions during the Q&A, and all the questions will be answered at the end of a session with the panelists. If you are interested in asking the question directly, you just need to raise your hand. You can see an icon where you can see what you have to do to raise your hand. We will wait just a little bit longer, and we will wait, and then after waiting, we'll start the session.
Muito bem. Então, nós vamos começar.
So we will start this webinar for the treatment and recovery of the alcohol use disorders, and we're going to have the participation of experts from the World Health Organization from our region, and examples of services that are available in our region and that are carrying out a superb job for self-help and for creating help and communities to support users with alcohol use policies so that we can improve the situation in the region and in different areas. After that, we will have the opportunity to hear from the largest help organization in the world, which is the AA, and we will hear from members of this organization about what the proposals that they have and who the clients are, and how the people can get together in a group. Therefore, I would like to give the floor to Dr. Renato Oliveira de Souza, who is the unit chief of mental health and substance use here at PAHO in Washington, D.C., and he will open our webinar.
Amazing how you speak such a good Portuguese. Good morning, good afternoon, and good evening to everyone. It's my pleasure to welcome colleagues, invited experts, and members of the public to this webinar. Thank you very much for being here with us today. Alcohol consumption is one of the leading risk factors for ill health globally and in the Americas. The prevalence of alcohol use disorders in the region is the highest in the world among women and second among men. The overall treatment gap for alcohol dependence is close to 80%. I hope most of you have participated or heard about the launch of Paola just 10 days ago. Paola is the first digital specialist on health and alcohol use, which is aimed at filling a gap in screening and brief interventions in health services. These interventions are aimed at reaching people before they have long-term problems and are dependent on alcohol. Today, we want to discuss alcohol use disorders, especially dependence, and the gaps and needs in treatment services and supports in the Americas. This includes the important role of non-professional mutual aid groups such as Alcoholics Anonymous and other recovery groups. Globally, fewer than 10% of people who have an alcohol use disorder receive appropriate care due to numerous barriers. These barriers include fear of treatment, privacy concerns, stigma, time conflicts, costs, and limited availability of services. At the same time, there is a vast scientific literature that shows the efficacy of treatment, and we will hear about the latest evidence on that today. We will have the pleasure of hearing from invited experts from WHO, academia, recovery groups across our region, and representatives from Alcoholics Anonymous about the best strategies for helping those with alcohol problems and how we can better cover the current gaps in care. Thank you to all of you, to our speakers for taking the time to share their expertise and experiences with us today, and for everyone who is in attendance to learn more about this important topic. Thank you very much on behalf of our unit. I'll now pass the floor back to Maristela Montero. Thank you.
Obrigada, Renato.
Thank you, Renato. For those who are not informed about this yet, PAHO launched last week a digital assistant specialized in health and topics relating to alcohol. It's the name we gave to this digital assistant is Paola, and it's available in English, Spanish, and Portuguese, and it shares reliable information that has been fully updated regarding alcohol use for any kind of person. And for those who might be interested, it will also access the risk for alcohol consumption problems. And those who have a high risk, there is a proposal for a brief intervention. And if the person is available to reduce the consumption, this is available through Paola. This is one of the many services that are necessary in health assistance, but we know that dependence requires more resources in interaction with health professionals who are fully specialized in this area. So now I give the floor to Dr. Thomas Baber, who will talk about the efficacy of treatment for alcohol dependence. He is a professor in chief of the community medicine department and public health of the Connecticut University, which is part of medical school. And he has received an award for health services for doctors and public health and community medicine. He is a publisher of Addiction magazine and is very interested in research in many different fields, such as screening, alcohol and drug intervention, diagnostics, brief interventions, treatment assessment, public health, and alcohol and drugs in general. So, Dr. Weber, you have the floor.
Thank you very much. And it's great to be here with so many people interested in the effectiveness of treatment for alcohol-related problems. What I'm going to talk about very quickly is what we know from scientific research about the effectiveness of treatment and how treatment works. And in fact, over the past 40 or 50 years, scientists in many different disciplines have learned a great deal about how treatment works and how effective it is. And I'm going to share some of that with you. Treatment is one of the first things that modern societies think about when alcohol problems become prevalent in a society. And researchers have been charged with trying to figure out how well treatment changes the course of the natural progression of alcohol dependence, which for many people leads to premature death and is a terrible burden, not only on their families and themselves, but on society in general. And generally, the general public and policymakers who fund research want to know two things. Does treatment work well enough to alter the course of an alcoholic self-destructive behavior? And can the totality of treatment, when you look at all of the treatments that are available, including the recovery services and mutual help organizations and screening and brief intervention, when you put all of that together, does it add up to having a significant impact on the overall burden of death, premature mortality, alcohol-related problems in a society? And that includes disease and crime and violence and traffic fatalities. And so I'll share some of that research with you. Let's start with interventions for people who are hazardous drinking. They're drinking at levels that in the future would lead to alcohol-related problems, but they're not alcoholics now, as well as people who are consuming alcohol, which is causing problems with them, but they do not have an alcohol dependence syndrome, which is a set of signs and symptoms that include physical withdrawal, a high degree of tolerance on alcohol, impaired control over drinking, craving for alcohol. All of these things constitute the dependence syndrome. But many people experience alcohol-related problems without having a dependence syndrome. And for that reason, screening, brief intervention, and referral to treatment is a set of clinical procedures that have been developed to identify people early as either hazardous drinkers people at risk, harmful drinkers, people whose drinking is now leading to problems, but who are not dependent, and people who have an alcohol dependence syndrome. And over the past 40 years or so, there have been several hundred empirical studies on screening, brief intervention, and referral to treatment. And a number of screening tests have been developed to identify people who are at these different levels of severity or risk, including Paola, and over 100 randomized clinical trials. And what we found from randomized clinical trials conducted in emergency departments, in primary care, and small business organizations, and a variety of other settings, is that brief advice to reduce a person's drinking and feedback about their current risk levels can alter a person's drinking in the short term and up to several years, and lead to a reduction in future problems. And at the same time, what we're learning is that when you develop these programs, and in some countries like Brazil, they've been quite extensive, and try to train primary care workers throughout the healthcare system to do the screening and the brief interventions. What has been found is that there are difficulties in changing our existing healthcare systems to the point that we can have a major impact. But gradually, alcohol screening, brief intervention, and referral to treatment have become integrated with general healthcare systems, and it is a good approach to invest in. There are many other approaches that have been developed to deal with people with alcohol dependence once they've been referred to treatment. Detoxification to reduce the effects of a abstinence withdrawal syndrome. Residential treatment, which has been used for over 100 years to bring people to a safe and secure setting and to detoxify them and then begin to work on their recovery. Outpatient settings, which have now become the main arm of our health services system to deal with alcohol problems. And they use various therapeutic modalities, including cognitive behavioral therapy, motivational enhancement, facilitating contact with mutual help organizations, and contingency management. All of these approaches we'll talk about in a minute in terms of their effectiveness. And finally, we now have pharmacological interventions, drugs that reduce craving for alcohol and help people with alcohol dependence control their drinking. Is alcohol treatment effective? Well, what we know about it seems to indicate that it is reasonably effective for many people. Those who obtain help for a drinking problem have better outcomes over the course of a year or two than people who don't get into treatment. The type of help they receive, whether it's psychotherapy or someone gets an intervention for several weeks or several months from a qualified health professional. The intensity and duration of treatment are not generally associated with outcome. That is, up to a point, more treatment is better, and it's better to distribute it over a period of time. But for the most part, if it's delivered over the course of a month or two, that is going to be a sufficient dose. And interestingly, except for people who are severely compromised because of their health conditions or psychiatric problems, or their lack of resources in the community, if they're homeless, medically based inpatient treatments are not demonstrably more effective. Little evidence that any one psychotherapy or pharmacological approach is superior to the others. So we have a variety of interventions. Almost all of them are effective in the short term, and that's good news. Treatment outcomes, to the extent they've been studied in a few countries, suggest that between 15 and as much as 35% of patients will achieve sobriety over the course of a year following. We know much less about long-term effectiveness of treatment over the course of 3 to 5 or 10 years. And for many people, treatment is more along the lines of treatment for a chronic condition like heart disease or diabetes, where a number of interventions have to be tried over the course of a person's drinking career. And even if complete abstinence is not achieved, and that is pretty much the gold standard, treatment can still be effective in the short term and in the long term in decreasing heavy drinking episodes, improving physical health, and improving psychosocial functioning, which leads to reductions in healthcare costs. So in addition to the 25% or so of people who respond with abstinence, even many other people, sometimes up to 50 or 75%, at least in the short run, are going to reduce the extent of their drinking to the point where their healthcare costs are reduced. We'll be hearing later in this webinar about mutual help interventions, but there have been several large-scale, well-designed studies of AA that shows that when it's added to regular treatment, when people are connected, particularly during the treatment episode itself, that AA provides an incremental benefit over the ordinary effectiveness of a treatment intervention. And it therefore can increase long-term abstinence, especially for patients who have social networks that have a lot of drinkers. So AA, in some respects, works by changing the person's social environment from heavy drinkers to people who are abstinent. Cost considerations are important, and the news is good here where it's been studied. Inpatient programs lasting from 4 weeks to several months do not necessarily have higher success rates, but they cost more, so that outpatient treatment for many patients is a less costly alternative. Patients can be detoxified at home in many cases. Partial hospitals, people who come for a period of a month or two every day, can get the same quality of treatment that they would get in residential care. And in some populations, outpatient programs produce results, as I mentioned, comparable to in-person programs. Finally, digital technologies have not been evaluated extensively, but programs like Paola are likely to be effective for outpatient types of treatment like cognitive behavioral therapy. So what have we learned? Well, access to treatment is very important. So if we can make these various treatments available, people are likely to take advantage of them. Comorbidities, particularly psychiatric comorbidities, need to be taken into account, as well as a person's dependence severity and their social support, and family history of alcohol dependence. So all of these things may contribute to worse outcomes. But if we can identify people who have this more severe vulnerability to alcohol dependence, we can give them more dedicated and more targeted treatment. Finally, the question is, when you add up all of the different interventions that have been evaluated, and make them available to people in a community, in a municipality, in a country, is it sufficient to alter the trends in alcohol problems in society? And can they reduce population rates? And what we've learned when AA becomes more available, what we've learned when treatment opportunities with professional help become more available, and what we've learned based on modeling studies that estimate the additive contributions of individual interventions in primary care and specialized treatment settings. What we've learned from all of this is that it is possible to alter the course of alcohol-related problems, but we don't know enough about it to say that this is the solution to society's problems with alcohol. In fact, there are other types of interventions, those particularly encapsulated in the WHO SAFER initiative, which impact heavy drinkers, reduce the rates of alcohol dependence in a society, as well as traffic fatalities. And these SAFER initiatives, particularly bans on marketing, increased taxes on alcohol products, and restrictions on availability, are probably a less expensive way of dealing with society's problems than with treatment. That doesn't mean that we don't need treatment. We need to invest in treatment, and people in the treatment world who are professionals need to be advocates for evidence-based treatment. So that's pretty much what we know from the research base. Thank you.
Muito obrigada, Tom. Excelente.
Thank you, Tom. This was a great presentation. I will now give the floor to my colleague, Dr. Vladimir Poznak, who is the head of alcohol, drugs, and addictive behavior of the WHO in Geneva. He is going to talk about the gaps in treatment coverage at global level.
Thank you very much, Maristela. Hello, everybody. It's my pleasure to be a part of this panel. I would like to share my screen now, but somebody has to stop sharing another screen. So could you please do that? Okay. And then I think I can now share my screen. And in my short intervention, I will try to answer the questions: what treatment modalities do we currently have, and how can we increase treatment coverage? And let me give first several figures. First of all, approximately half of the global population aged 15 plus consume alcoholic beverages, but it comes at significant cost. And in the world, WHO estimates indicate that almost 300 million people have alcohol use disorders. New estimates of prevalence of alcohol use disorders in the world will be released by WHO next year. If to look at the distribution of how frequent alcohol use disorders are present in populations, then the leading region in the world is European region, which is also known for the highest level of alcohol consumption in populations, followed by Americas. And as was mentioned in the introductory remarks of Dr. Oliveira, the prevalence of alcohol use disorders among women is the highest in the world. What are the trajectories that we should consider when we are talking about the treatment for alcohol use disorders? And I should say that when it comes to treatment, we should consider not only alcohol use disorders, but more broader concept of disorders due to alcohol use. In 2022, the new 11th revision of International Classification of Diseases will start to be operational and fully implemented in member states, in countries around the world. And in ICD, there are several codes that cover the spectrum of conditions which could be the target of interventions from health professionals and, in fact, from digital interventions like what was mentioned already, what was launched recently by PAHO. So among the people who don't drink, and this more than half of the adult population don't drink alcohol, at least in the last 12 months, some of these people are those who are in full remission, treated or without treatment for alcohol use disorders. Some people consume alcohol at relatively lower risk alcohol doses, but a significant proportion of people, and in some populations it's more than half, and particularly among young people, more than half of young people consume alcoholic beverages in higher risk situations in the episodes which are associated with the very high levels and dangerous context of alcohol consumption, which would be considered as hazardous alcohol use. And in ICD-11, we introduced a new category, which is called episode of harmful alcohol use, with an intention to increase coverage of screening and brief interventions for conditions which can be associated and caused by the risky or alcohol use in higher dosages or in particular contexts. And finally, we have the alcohol use disorders, which in WHO nomenclature consists of two major diagnostic categories: harmful pattern of alcohol use and alcohol dependence. When more significant, more substantial, more structured interventions normally are needed, as was presented by Tom Baber. What are treatment modalities that we currently have for addressing alcohol use disorders? First, as was already well described, screening, brief interventions, and referral to treatment, which is more appropriate for hazardous and harmful drinking, though there are a lot of debates about potential benefits of screening and brief interventions, even in cases of alcohol dependence. It's evidence-based psychosocial interventions, which are more structured, which are more intensive, which are based on different modalities and different approaches of psychotherapy or psychological impact on behaviors. Evidence-based pharmacological interventions, which now go even beyond three medicines which were listed in Tom Baber's presentation, but these three are indeed the recommended options for treatment in primary healthcare, and only in specialized services some other medicines can be used for management of alcohol use disorders. And recovery management, which can include 12-step peer support like Alcohol Anonymous groups, which is an important part of community management and of peer-supported management of alcohol use disorders. And of course, treatment of co-occurring mental and physical health conditions is an overall part of treatment approaches to these conditions. Where the treatment can be provided. And this is the slide illustrating the service organization for treatment of drug use disorders largely, but it's applicable to alcohol use disorders as well. So at the bottom of this pyramid is self-care and informal community care, which may include digital interventions, web-based open access interventions, peer support groups like Alcohol Anonymous, and they come at relatively low cost and have a potential to achieve a higher coverage of people in need. Then, when it comes to healthcare services, the settings which are important for delivering interventions are primary healthcare and non-specialized health services, like, for example, for non-communicable diseases, for infectious diseases, for injuries, in trauma centers, when interventions can be delivered despite the fact that the conditions which are the reason for coming to the services are far from actually alcohol use disorders. And specialized services for treatment of alcohol use disorders, which are more costly, which are more applicable to people with moderate or severe cases of alcohol use disorders. And at the top of the pyramid is long stay residential service, usually expensive, very seldom is being implemented on a large scale in health systems. And this is required or can be useful for particular cases in populations of severe or comorbid alcohol use disorders. Though alcohol use disorders are known for centuries, in fact, but the treatment and coverage of treatment is notoriously low, almost in all populations, not to speak about low and middle income countries, but even in high income countries, the coverage of treatment for alcohol use disorders does not exceed 20%, at best on average approximate 10%. But when we are talking about the treatment coverage, and on the previous slide, I've shown that in SDG 2030 agenda, increasing treatment coverage is one of the sustainable development health targets. The concept of treatment coverage is very broad and contains several categories. When we are talking about availability coverage, so it means that when people can just have an access to the services which exist in the population, then you can have a relatively high figures like 10–20%. But what we are interested particularly in, that treatment is being provided in interventions which have a proven efficacy, though the different treatment modalities may have very comparable the treatment outcomes and treatment effectiveness, as was shown by Professor Baber, but still there are some treatment approaches which do not have any evidence of effectiveness. And if to speak about effective coverage, the percentage of coverage in many countries would be not higher than 2–3% of those in need. There is a very significant challenge in estimating treatment coverage. And if to ask what is the global coverage for treatment of alcohol use disorders, these figures are always very approximate, is their estimation. And to improve these estimates is a significant challenge for WHO, for any national organization which makes this task for itself in order to report on SDG targets. So in SDG monitoring framework, treatment coverage is included as contact coverage. So basically, it's how many people are using services from the total number of those in need. In WHO now, we are working towards different approach, which may be considered as a proxy measure to contact coverage, and this is called Service Capacity Index for Substance Use Disorders, when based on the key elements of the health systems for management of substance use disorders, we estimate how well developed different service elements are available in a given country. And we can calculate this index for countries based on the direct data submitted by countries to WHO, but also in cases when this data is missing, indirect or imputed data. Now we have these estimates for almost all countries, all WHO member states, and we'll release this data next year. What can be done to improve treatment coverage and to improve treatment? It's a very complex question. And of course, one of the solutions which particularly are popular now after in the COVID-19 pandemic is to look at the digital interventions and the web-based interventions in artificial intelligence approaches, what has been used in PAHO. And we are looking forward to see how what might be the impact and effectiveness of these interventions. But if to speak about the health systems and what can be improved in health systems to increase the coverage, there are several key elements. it's the elements of governance, it's an element of financing, and you can forget about higher treatment coverage if treatment of alcohol use disorders is not included in the basic health insurance packages or in the core insurance packages. But also the service delivery, including workforce development, medicines available for management of these conditions, and health infrastructure for different modalities and different treatment interventions, which have proven to be effective. Well, it's a huge task, but hopefully with all efforts, including the civil society groups, civil society advocacy, and self-help groups like Alcohol Anonymous, definitely the situation can be improved to the better. Thank you very much. Let's stop here.
Muito
Very
obrigada.
much, Vladimir, for this excellent presentation, as always.
Nós estamos pouquinho atrasados,
I think that we are running a little late. Thank you so much for having accelerated your presentation. We shall now give the floor, and we're going to hear examples from the region, the US, Brazil, and then international AA. I'd like to introduce you our next speaker, Tiffany Hall, who is the Executive Director of the Recovery Alaska program. She was born and was raised in Alaska, and she was recognized as one of the first individuals below 40 years old in Alaska in 2016 to be awarded by the Oregon University 2019. And from Grant Makers in Health in 2021. I'm sorry about this. I'm translating mentally from English into Portuguese. She was awarded for all her advocacy and work. She was awarded the Andy Hyman Award. She's also part of the American NGO, US Alcohol Policy Alliance. And she was by an NGO who works in leadership activities in Alaska. I'm so sorry about my very poor translation. I was not prepared to be speaking Portuguese today, but you have the floor. Tiffany Hall, please. Thank you.
Thank you so much. Let me share my screen. Okay, I'm guessing that you all can see that, and if not, somebody just give me a wave. Hi, everyone. I'm Tiffany. I use she, her pronouns. I'm zooming in from the land of the Dena'ina people here in Anchorage, Alaska. I am with Recover Alaska. I am a mother to a toddler who you may see behind me today, and I'm a person in long-term recovery from co-occurring alcohol use and anxiety disorders since 2009. I'm really grateful to be here with you today, and I'll try to go quickly. I know we're running a little bit behind. So just know that anyone may reach out to me at recoveralaska.org. All of my information is there and easy to find. So I'll just try to move kind of quickly. So Recover Alaska works to reduce excessive alcohol use and harms across the state so that all Alaskans are empowered to achieve our full potential. I think all of you know the harms of alcohol. Alaskans are dying at rates twice as high as the rest of the United States, and alcohol kills more people than opioids, meth, and all other illicit substances combined in Alaska. And so we do focus specifically on alcohol, but work with a lot of organizations that focus on other substances as well, because we know how related they all are. Recover Alaska is a funders initiative, and so I have listed here our primary funders from within the state, as well as some national funders. A lot of people ask how we get funding because we do a lot of advocacy work, and we are just really lucky to have funders who believe in advocacy and policy change and allow us to do that work. We have to follow all of the lobbying laws, but they let us do that, which is really incredible. Recover is not a direct service provider. We work on systems change, and so we try to look at the bigger picture and consider the roles that other people can play outside of traditional kind of treatment providers or other direct service providers to see how the rest of the community can help with problems of alcohol in the state. And, you know, alcohol is often always talked about as an individual choice and a personal moral failing, but that only stigmatizes the disease more and makes it more difficult to change internally as well as change as part of the society. And so we are really trying to address systems of harm that impact alcohol use, like poverty and lack of housing and access to education, and thinking about systems of oppression like racism and colonization, because just like they impact our everyday life, they definitely impact alcohol use disorders. And so as part of our work, we also have to address equity and justice. So at Recover Alaska, we do that by supporting staff to do trainings on diversity and equity and inclusion. We also tried to change our governance model to make it more of a flattened hierarchy, so there aren't hierarchies of power. So we have a consent-based decision-making model. And we try to always work with people with lived experience and people who look like the folks we're trying to serve. And we pay people for their lived experience to try to just make things more equitable. And then externally, we have also led trainings on diversity and racial bias, as well as work more specifically focused on alcohol. So the work that we do is in 4 primary categories. We do advocacy to change policy to create a safer and more equitable built environment. We do social norms change to try to reduce stigma around alcohol use disorders and celebrate recovery and sobriety. We coordinate an alcohol misuse prevention alliance across the state. And we do access to care work, trying to increase information about services and see how we can help to expand resources. So for advocacy, we've been working for over 10 years on a big bill at the state level to try to create a lot of different policy change to reduce license types and to keep population limits. Recently at the local level, we were able to pass an alcohol tax in Anchorage. Alcohol taxes are one of the best public health policies that reduce the most dangerous drinking, excessive and underage drinking, reduces violence and vehicle crashes and alcohol-related disease and death. So people had tried for many years to pass that in Anchorage, and in 2020, we were finally able to pass that. And the big thing is that the reason they're so hard is because big alcohol has so much power and money. But we had been doing a lot of polls, and we saw that people, Alaskans were in favor of an alcohol tax. And so we knew we just had to raise enough money to have a campaign big enough to challenge big alcohol. And so we just got to work fundraising and finding partnerships. Sorry, I'm trying to go pretty quickly. We also do a lot of social norms work. And so we try to meet people where they are. And so we make sure to talk to people who look and sound and feel like the populations we're trying to serve. And so we do focus groups and pay people to ask them, you know, what would have helped you when you were struggling with alcohol, or what would help you now while you're still struggling with alcohol, or what would have helped you as your family member was struggling. And so we do campaigns on social media and TV and radio and word of mouth. And so this is where it's also really helpful to try to build partnerships across the state to help us get the word out. So these images are from a recent campaign that we did during COVID based on the increased needs that we saw during COVID. About a third of Alaskans increased their alcohol use to deal with stress from the pandemic. And over half of Alaskans said that it was really challenging to find treatment during the pandemic, that they couldn't get into mental health or to alcohol use disorder treatments. And so we were trying to address that as well. We did a poll in 2018, and we're doing another poll again next spring to understand perceptions and beliefs around alcohol around the state of Alaska to help us guide our initiatives and our messages. And so the next one we're doing is around drinking while pregnant. About 1 in 5 Alaskans think that it's okay to have 1 or more drinks while pregnant, and we know that that is not true. And so when we looked at the regions, there are 2 regions within the state who almost 1 in 3 people think it's okay to drink alcohol. So we are going to focus on those regions and do positive social norm campaigns. So we're doing focus groups where we're asking people what strengths are and how they got through pregnancy sober and how to support loved ones. So we're going to target our campaign toward spouses and partners and medical providers to help them be able to give clear information and to support people while they're pregnant. We know that shame and guilt and stigma don't work in messaging or in any type of prevention. And so we really always try to focus on strengths-based messaging and positive messaging. We also know that connection to culture is a protective factor. And so we try to really highlight that. Alaska Native people are dying at rates 10 times higher than the rest of the United States. But connection to culture is helpful, is protective. It's not a risk. They also have the largest sober population out of any race or ethnicity. So they're just kind of at both ends of the scale. And we know that the medical model doesn't always work. Medical treatment or AA doesn't always work in small villages because there's a lot of historical trauma from religious people who came to colonize and took their children away to boarding schools and punished them for speaking their language. And so AA is very present throughout Alaska, and we know that it doesn't work for everyone. And so we try to work with our local AA folks to kind of hear what they are hearing so we can know where we need to try to help connect folks to culture or other support. And we made podcasts talking about sobriety. We have video blogs where people are tasting non-alcoholic beverages and talk about a screening tool on our website where people can fill in numbers about how much they're drinking and see if they need support. And then we've been working with an app called Step Away, which has 4 clinical trials from the NIAAA, and we are giving out free access codes so people can use this app to help reduce or quit drinking. We'll have to add a link to Paola now that we know about that. We'll get it on our website. We're also doing pilots with a group to try to look at integrated care and have a resource navigator connect folks to primary care as well as mental health, as well as addiction service, medication assisted treatment. or other sports they may need. Also looking at how to proliferate expert. Dr. Faber was talking about not only for healthcare providers, Alaska, talk to everyone to give experts to people. And then finally, we're in the beginning stages of also looking into a call line for the entire state for resource navigation and peer support. We made a toolkit with the state to help employers. So especially as people are coming back to work from COVID, maybe they're coming back to the office, but now maybe they have issues with alcohol, or maybe they did before, to try to help them understand how to support them instead of just fire them, and get them connected to the resources that are available. And then we have this statewide prevention alliance, and we have regional co-chairs throughout the state to help us understand the issues in different parts of the state. And then we have, we also look at the state as a prevention landscape map. So who we connect with in suicide or violence or other substance prevention. And Alaska-alliance.org is another website you can go to. I want to hear from the other speakers, but the work that we do really tries to connect the brain with the heart. And we do try to follow evidence-based practices, but we also have to ask ourselves where the evidence is coming from. So much of rural Alaska and Alaska Native practices aren't backed up by research because there's not enough funding, or it's not a big enough population. And so we just don't have the evidence. So we also just make sure that we're asking people what might help them, and that we believe them, and that we make sure to, again, highlight strengths and support people the best we can that way. So please connect with us. We're on all these different types of social media. Again, please reach out to me with any more questions. Thank you so much for having me here today.
Thank you very much, Tiffany. It has been great to know more about your program. And indeed, we are a little bit late, 15 minutes late. So I'm not, I'm moving now to the next presenter. A Grazi Santoro, que é brasileira.
Grazi Santoro, who is Brazilian.
Está sóbria há mais de 13
She's been sober for over 13 years. She is a survivor of violence. She's a feminist, an activist. She is a life coach and a behavior analyst, as well as a facilitator in health dialogues through non-violent communication. Over her career, she was an executive at multinational companies, and she used to hide her problem. But in 2020, she was tired of hiding the situation, and with the absurd increase in the number of women who were alcohol user in Brazil, she then founded and consolidated the Women's Alcoholism Association. She's founder and current president. It was created by women for women who might be having problems in alcohol use. So I'm going to share Grazi's presentation now. Grazi.
Obrigada, Maristela, obrigada, Organização.
Thank you, Maristela. Thank you, Pajo, for inviting me. I am very moved, and I'm also very nervous about this. We started our association in less than a couple of years. In February 2022, we will be 2 years old, and the initial idea was to create some shelter for women without judging them, without any prejudice. Our mission is to help women who are undergoing through suffering due to the fact that they drink in a certain way, and we have given shelter to more than 1,000 women in all the Brazilian states, and some that are living abroad, like the US, Portugal, Italy, Ireland, and England. And we are committed with the 2030 agenda of the UN in order to empower these women and show them the power that they have when they stop drinking. So when they come to us, they fill out a survey that will help us put together our project. Our methodology focus on the 12 steps, that AA has offered to us, but we also have a group of psychologists, we have nutritional follow-up, we have our own meetings, we have a support group for families, and sometimes we have men or women who use alcohol, and based on this research, we can adjust our work. More than 80% of the women who get to us have been victims of sexual or physical violence. So we have a group of alcoholic women who receive support to survive this violence. We also have a specific group to help women who use alcohol but are mother and are feeling guilty because they see themselves as not being good women. And we talk about balance in education, showing that it's not just up to them, and we help these women to overcome guilt, and through abstinence, they are able to establish a healthy family environment. We have group therapy for lesbian, bisexual, and trans women who are about 30% of our girls, as I call them. I have group therapy for Black women, which are about 38% of our the women who abuse alcohol. And we believe that treatment is a lot more than stopping to drink. It's finding new meanings in life, understanding your family history, understanding abuse that women go through, especially here in Brazil, where violence numbers are higher every day. So we try to show these women that they have to understand the family history, with that helping them find different meaning in their lives by stopping to drink. Our structure is configured as such, and basically our work structure is made up of voluntary work, either former or current alcoholic women. And we have 17 groups that we call petals, and they are headed by people who are recovering from alcohol abuse. And this has a lot to do with my history as a businesswoman who is trying to hide. And I'm always thinking about women who are going through a lot of pain because they don't have the backup of the workplace to help them and help them overcome that alcohol abuse. So we here show that our associations with nonprofit is headed by powerful women who are alcohol users, but they are recovering from alcohol abuse. So we are more than 57 people working as voluntary, and I would like to thank everybody who's here with us. This is our fight, this is our cause, this is what we build daily with a lot of love. So we have 57 people working with us. All of them are psychologists. They work with recovery. And in December, we are going to
mas nós temos núcleo específico que chama núcleo de renda, porque não é apenas a saúde física da
the speaker says that she forgot to mention that they have a special hub for financial health. So most of the women here come from a situation of abuse and violence, and we have to help them, not just stopping with the drinking, but help them find a new place professionally. 40% of our women are employed, and they have to be emotionally and financially independent. Our funding is due to voluntary contribution by the women who support us selling of our products like mugs, t-shirts, and agendas for 2022. We're going to have a 2022 workshop that will discuss a healthy, sober life. And in order to be sober, we have to take care of our health, to take care of life in society, and how this life is joyful, not just considering the problem, but also considering the solution. Our funding is based on this type of contribution. And with this slide, I would like to thank all the organizations in Brazil who have been caring for us and have been a shelter to all these women. I am very grateful to all of these associations, including to the AA. We take our ladies, we are a bridge between the women who come to us and these other associations, and they feel safe and strong to be part of these meetings. So this is my last slide, and I would just like to say thank you so much for all of us, for all of those who are part of our petals and who believe in our project. Thank you, Maristela, for all of your support and all the love you have given us. Thank you. It's very moving to hear your presentation. It's great work. So now we are going to start a different session. We want to understand better what AA is as an international organization, and we're going to hear from members. The first person who is going to talk to us is Dr. Almuni.
Dr. Mooney is a non-alcoholic chair of the General Service Board of the AA in the US and Canada. He is recognized internationally as an honorary physician leader. He has board certified in the specialty of family medicine since 1979. He has provided medical care in the specialty of family, behavioral, community, and addiction medicine for 45 years. He also currently serves as a Class A non-alcoholic trustee on the General Service Board of Alcoholics Anonymous in US, Canada. Although the AA is a non-professional Class A, trustees are chosen for their professional backgrounds and their unique personal experience that they can bring to AA. So not a spokesperson for AA, noting they are not members themselves. They use their full names in public without being in conflict with AA's principle of anonymity. The floor is with you.
Good afternoon, everyone. My name is Al Mooney, and I am a Class A trustee for Alcoholics Anonymous. I'm also a physician. I've practiced addiction and family medicine for over half a century, or nearly half a century, and some work before medical school and during medical school puts me up at that half a century mark, I'm pretty sure. What I would like to do, my job here is very simple, but it's not easy. I'm going to show you some slides, and I want to introduce myself because I really get involved in the clinical stuff, and I've heard some wonderful clinical information, and I'm so glad that I can represent a fellowship of recovery, that being Alcoholics Anonymous, who can offer solutions when many people have not found solutions before. I can do that, I hope, by sharing a little bit about my relationship with Alcoholics Anonymous. I'm 73 years old, and my relationship with AA goes back probably longer than most people in the audience have been born. So I have watched research, I've watched cures, I've watched things come and go. And for 4 generations, I've observed the success of Alcoholics Anonymous. And Alcoholics Anonymous has some traits that more than most people would realize needs the friendship of professionals and family and friends. I want to talk a little bit about that because people who are at this webinar are essential to AA's health and AA's ability to be there when people are spiraling down in life from an alcohol problem. And AA works for, in a lot of cases, for a lot of things beyond alcohol, but I also want to focus on alcohol because one of the unifying factors that makes AA so successful is that AA members revolve around the context of alcohol as being the problem. People who stay sober and find a way to not need alcohol do very, very well in life. And AA found that out in 1935, wrote a book about it in 1939. And now, finally, in my profession of medicine, we're beginning to study Alcoholics Anonymous. AA doesn't do its own research and doesn't do treatment research, but people are looking at AA very, very seriously. And I'm so proud to be part of a profession that's beginning to open its eyes to Alcoholics Anonymous, to the effectiveness of Alcoholics Anonymous. What I would like to do is, and I'm not a PowerPoint person, but sometimes there's some images on PowerPoint that we might be able to take home more meaning. And that's what I want to do is to, let's see. There we go. So I'm here to talk about Alcoholics Anonymous. And as a Class A trustee, I'm not confined to anonymity. One of the traditions of Alcoholics Anonymous is to be anonymous at the level of press, radio, and films. Many people who did not feel they had privacy in their search for a way to live without alcohol would probably drop out in the weeds. And so AA has made itself available for people who are looking for some privacy. There are no records, there's no roster. Every group of members who get together to help each other work autonomously according to what they decide to do as a group to help each other. I mean, it's so cool, and it's so opposite of all the other organizations and societies I've been a member. So I want to share a little bit about how AA does works its methods and its structure. Alcoholics Anonymous is an international fellowship of people who have found a solution to their drinking problem. AA is non-professional, self-supporting, multiracial, apolitical, and available almost everywhere. And added to that, I'd say for free. I'll talk about that in a minute when the research out of the Cochrane Library now has begun to talk about AA's effectiveness and document the evidence-based part of the AA success. There's no age or education requirement, and membership is open to anyone who wants to do something about their drinking. The only membership requirement is a desire to stop drinking. There's no diagnosis, no tests, no nothing like we're so used to, which is part of the reason that AA is such a good friend of the medical profession, where people have all kind of fears, some of them legitimate, but there are things that we do in our medical profession that AA does not do. There are a lot of things that we do in healthcare and medicine that AA doesn't do. So it's a marriage built in heaven, in my opinion. I mentioned trustees. Well, here I'm not even qualified for membership in AA, and yet I'm one of 7 non-alcoholic trustees. Part of the importance early in AA was recognized that good relationships with professionals, doctors, ministers, social workers, leaders in society, even accountants and lawyers are important in AA's relationship with the people it serves. So, and it evolved, but AA has 21 members of its board of trustees. 7 of us are non-alcoholic. So there's no way we run the show and wouldn't want to. AA's Alcoholics in Recovery have proven that they can run the show pretty doggone well. And so we do have a variety of professionals that share input. One of my tasks as a Class A trustee is to provide a perspective from my background, which is healthcare, medicine, addiction treatment. And I've done my share of all those things, but probably one of the most proud things I've ever done is build a solid, long-term, maybe call it lifelong term, relationship with Alcoholics Anonymous. And you too can do that. And it can be very important, because AA is not an organization that you can give money to. I've tried and they won't take it. If you have a lot of money, I mean, who else won't take your money? Well, AA has that kind of structure, and it works pretty doggone well. But the help AA needs is to begin to find a source of new members whose lives can be saved as they find a solution to their drinking problem. Let me get my slides working here, and I know I've got to cover a lot of ground. So what's wrong, slides? There we go. So I want to impress that AA can serve as a resource for professionals, and AA also can serve, and professionals can also be a resource for Alcoholics Anonymous. AA was originally, even though AA has a number of misconceptions and there's some misinformation, AA was founded by friends who had a heart for the alcoholic who was still suffering. If it hadn't been for those friends early in the 1930s, 1935 through 39, AA might not exist as it does today. But it began in 1935. Let's see. It began in 1935 when an alcoholic named Bill Wilson was impressed that he got sober. He didn't know how he was going to get sober. He had relapsed many times, but he figured out through the help of his wife, Lois, who started Al-Anon, which is the family recovery fellowship. Bill figured out that there was therapeutic value in helping another alcoholic. The big book says nothing helps an alcoholic stay sober more than helping another alcoholic find a path to recovery. So Bill did that, and then some things happened that he was away from his recovery path, and plus it seems nobody else got sober when it was just Bill. But he went to Ohio, to Akron, Ohio. He found a physician named Bob S. Dr. Bob was AA number 2. And together they both stayed sober and they fed off of each other in a way that it attracted others. Eventually, they had 100 people who were kind of amazed that they had a hopeless condition. They had proven that to themselves for decades. And now they were staying sober. And not only staying sober, they had both returned to a productive, good life, along with about 98 other alcoholics. And they wrote a book called Alcoholics Anonymous. There's a beautiful history that I won't get into there. Bill came back to New York, Bob stayed in Akron, and there were two twins cities with AA. And then it spread real rapidly over the next 10 years around the whole country. And as they developed the program of Alcoholics Anonymous, it developed into what we call a program of action. The steps incorporate the message of AA's success. There are also the traditions that structure meetings, and I'll be glad to talk about those in more depth at another time. But we don't have the time today. But the 12 steps of AA are evolved. No committee got together and decided what they were going to be. But steps 1, 2, and 3 say that it's important to change our attitude about life and alcohol. And step 1 says there's a problem, it's me. Step 2 says there's a solution, it's not me. Step 3 says there's a way to put the solution to work on the problem. Steps 4 through 9 are action steps in a way that they produce the outcome of sobriety and recovery. Steps 10, 11, and 12 are what we call what some people call the maintenance steps, where now that you've gotten what you need in life and recovery by step 9, 10, 11, and 12 are the steps that allow us to relate to our society and where we draw our strength in a way to continue that process. It was interesting to me that, and the traditions, I'll say one word about the traditions because they are important, but the traditions are the way the membership and the groups relate to each other. Most of the membership, there are no rules, there's no governance. Each group kind of in its own chaotic way decides which way it wants to go. It's completely autonomous, but the traditions, say where the authority comes from, who is our target, how do we do public relations, when can you be a member? There are a number of things that go into the traditions that help AA's structure in a very loose way continue to do its job. Among those important things that the traditions talk about is anonymity. Initially, AAs were worried that they had such a great way to stay sober that they were going to be swamped and wouldn't be able to feed their families. Well, it turned out it didn't work out quite that way, even though there are 2 million members around the world now, at least, and 80,000 or so groups. It's been quite successful, and we'll talk about some research that we are glad happened in just a second too. But anonymity eventually became a key principle of Alcoholics Anonymous success, because alcoholics began to develop ego issues and things that that can interfere with sobriety and compromise the effectiveness of the group relationships. So anonymity, particularly at the level of press, radio, and films, becomes critical in AA's success. It is not a secret society. AAs, with time under their belt, are always, in my experience, glad to help reach out for people who are in trouble, help answer calls for people that want to get help, because the lifeblood of sobriety for an AA member is carrying the message. So anonymity is a little easy to misconstrue from the outside, but remember, private, not secret. There also is research when the AA Big Book, I'm not going to turn my PowerPoint off, but the AA Big Book was written. It's called Alcoholics Anonymous. And at the end of the introduction to that book, AA invited scholarly research. And it took long enough for us scholars to get to the plate, but that has been done recently in a way that is remarkable. And I won't go into the details there either, but Cochrane.org, do a Google on Cochrane, COCHRANE. And these are the least conflicted, most honest researchers, or a library of that kind of research material. There's nothing better in the world. There are no conflicts of interest. They're not trying to sell anything. It's a wonderful group of scholars. And there's recently, March last year, 2020, they released research from Dr. Kelly at Harvard and Dr. Humphreys at Stanford that talk about AA's success. Good or bad, they lumped in their research, they lumped AA in with treatment. No, AA is not treatment, we know that, but for scholars, the category that research is tabulated in has AA in the treatment category. And AA came out, in the words of Dr. Kelly and Dr. Humphreys, right at the top of the list. And it was as effective as any other therapy there, with one wrinkle, I'll tell you. But the reason that they called it even higher on the list was because it's free, and the results of recovery in AA are sustained, which is pretty cool that things end up with such success. Now, the other thing they said, which is good for all of us who are looking at this from a healthcare standpoint, is they didn't say that AA works in a void by itself better than anything else, but they described, and it's already been mentioned here, but it's very important in my experience. They describe AA as something that works best when professionals, regardless of their philosophies and treatment modalities, link their clients to AA. So it's like, and the original writing of AA kind of said this, sometimes people are so sick when they reach out for help that they need some stability from the healthcare environment. Bill Wilson, for those of you that have any AA experience, calls it jittery and befogged. That AA doesn't have the vocabulary that it took us 4 years to learn in medical school, but they have a nice way to describe reality that alcoholics live in. So as we hear from a couple of our speakers who are AA members in a minute, hopefully you'll catch some of the things that we're talking about here. As an outsider, I don't describe these things as well as AA members can. So what does AA not do? Well, as I mentioned, it's not a secret society. It's not a religious society. It doesn't take your money. It's not affiliated with any treatment hospital. It doesn't do treatment or detox or anything that we think of treatment normally doing, but it collaborates very well with anybody who's interested in helping an alcoholic. But it doesn't solicit its own members. You won't get a diagnosis. So alcohol use disorder, a lot of the words we use, don't mean much in the AA universe, because AA allows anybody in the membership who has a desire to stop drinking. So if a healthcare professional and their client says you need to stop drinking and they agree, AA is a great pathway for referral. AA doesn't keep attendance of cases. It doesn't provide housing, food, clothing. So some of the things you heard mentioned that treatment does need to be done, and make good partnerships with AA. Okay, what does AA do? That's worth a brief mention too. It's a recovery program. It's a recovery program that discusses AA principles and helps encourage people to follow those recovery principles that now we know work so well at group meetings. The group decides the topics and runs the meeting. AA members share their experience with anyone seeking help with a drinking problem. And this face-to-face activity seems to make a remarkable difference in the path that people take in recovery. There's also a trial period these last 2 years with COVID that has proven AA can survive in a virtual world. There are a number of people who have only been to AA on Zoom, and it works pretty doggone well. I've been in some meetings where I've watched those examples. AA has what we call a singleness of purpose. AA does so much to help so many people that it's really easy. But it's really easy to get kind of overwhelmed. And it's important to remember that AA addresses a person's relationship with alcohol. And then if someone can be successful stopping drinking, a lot of things get better in life. And that's important. I want to hit a couple of other things related to building a relationship with AA. If you are interested in doing that, there are sources to professionals for literature. I'll give you one email. You can go, or a website, aa.org is the website for AA, and you can get any professional can get access to AA's resources through that website. There are also local numbers for AA. You can find that on the internet. And I encourage healthcare professionals to, nose around a little bit and find who members of AA in your network are. They're often members of AA that, because of anonymity, not going to be waving the banner in front of you, but they're there ready to help too. There's a newsletter that can be available through the General Service Office for North America in New York, and that is international@aa.org is the email address for that. And Racy, who's in attendance here, Racy J, would be glad to respond to anybody's requests for professional information. And there's also another staff person in New York that manages what we call the committee that works on professional collaboration. And there's lots of AA literature. It would just take too much time to mention anything much more than the big book I've mentioned. AA also has a journal, a periodical for the society. It's called the Grapevine. And then for Spanish-speaking people, there's La Viña. Those are available too. Now, that is something, if you want to contribute to AA, buy a friend a subscription to one of those periodicals. I found it's a loophole that works for me. Or emphasize the diversity in AA, even though when it started in 1939, everything in our country was limited related to diversity, but AA has just really opened up religions, gender, color, nationality, creed, beliefs, politics. There's so much diversity that it's really amazing. So let me finish by encouraging people who are interested in kind of wrapping whatever treatment we do up in a bow and helping, move that person into a life of recovery that really has been now documented to be very, very effective. Remember the Cochrane group I was telling you about? Those guys, the weakness from people in my world is that the standard of evidence is too high. That's the only complaint I've ever heard about the Cochrane people. They don't even acknowledge that antibiotics work for children's ear infections. So if they say AA works, you can trust what they say. And I encourage people, particularly with a disease like World Health Organization says 3.3 million people die a year before COVID. We don't know what's happening now. That's every 10 seconds an alcoholic dies. If we're here 2 hours today, that's 720 people are dying from alcohol that were alive at the first of this meeting and now dead. So I contend that we have a little urgency to do. We know I'm codependent and think I can change the world. I'm not. But I think if we recruit enough individuals, we'll make a difference. And I really commend everybody in this audience for making a difference and to talk about their own way of making the difference. I want to turn things over to Marita from Brazil, and then Paz, who now lives in America but has spent a lot of her time in Central America. So let me close out there and thank you all for being here today to support recovery of people who are dying from alcohol. Thank you.
Muito obrigada, Dr. Moni, agora.
Thank you very much, Dr. Mooney. I will now give the floor to Maria. Maria Z. She is an AA member in Brazil. Please.
Ela não estará mostrando o.
She will not be turning on her camera,
Estará falando para nós
but she will be telling us
a jornada dela.
about her journey.
Ligue o microfone, por favor.
Please turn on your mic.
Alô, me escutam?
Can you hear me? Good afternoon.
Eu me chamo Maria,
I am Maria Z.
sou daqui do Brasil.
I'm from
Estou hoje em
Brazil.
São Paulo, capital.
Today, I am in São Paulo, the city capital. I am an alcohol consumer, and only thanks to God, I did not drink yesterday or today. I got to AA in 1988. I had a serious problem with alcoholism. However, I was not aware that alcoholism was a disease. I used to drink because I liked drinking. I used to drink because of its nice effects, but I had no idea that all of this had to do with some disease. And somebody watched the way I drank, looked at me and watched different times. And for a few years, my husband and myself separated 3 times. Many times he would leave the house and then come back because of my drinking. I really wanted to stop drinking, but I couldn't. And I would drink at parties because of joyful moments, etc. One day, somebody approached me. I went to the bakery to get bread. I would not even buy any bread anymore for my house from my drinking. But this day I did stop at the bakery to get bread. And this young guy approached me and he asked me whether I wanted to join AA. I did not understand what he meant. I did not know what he meant, but he did ask whether I wished to go. He insisted. In those times, we did not have the technology we have today. I used to have a pager, and I asked to call my husband through his secretary to tell him that I would come home a little later that evening. So I did follow this young man driving my company's car. When I got at his home, his wife said that he was not there anymore, that he had gone elsewhere. So I followed him. And when I went there, actually, he was not that young. He was a mature man. Actually, he gave his message. He explained why this was alcoholism and a disease, and there was a way out if I wanted to choose that. This was a Wednesday, and this group met in Olinda, which is the capital of culture in Pernambuco, the northeastern state of Brazil. This group is still there. It is called Santana. And when I asked this person whether he wanted to come with me, he was not there anymore. This was 23 years ago. I never met him again. I don't know where he is. All I know is that I am an AA member. When he talked to me, he said that something was really going to change my life, which was called steps, something that would help me walk forward if I admitted that I was an alcoholic. And I did. That recovered my sanity. I was like a mad woman. I used to drink desperately. My husband came back home. We've been together for 35 years. We have 2 kids, a beautiful little granddaughter. And it was God who helped me. I gave him my life, and everything that went on and goes on is thanks to him. Everything was wrong in my life. I recognized my mistakes. I confessed everything that I did wrong. And even today, I work on the steps. Today, I know what makes me angry, what may take me to drinking because of some anger or resentment or even luxury. But I control this. I'm allowed to control this. Today, I feel like a better person. I am humble in my daily practice. This is really good because I apologize to people who I have been mean to. This has saved my life. And today I feel really accomplished and I have flourished because I did meet AA. Today I'm in Sao Paulo because the structure I'm part of in Brazil is organizing this national meeting, which we call conference. All of us, all the representatives in Brazil have met here, but really I wanted to be here at this panel because I wanted to tell you this, that AA does work. When every day I think about my day or how I can improve how I live within my group, and unity is everything. I am very, very happy because God, through that one man who approached me, gave me his message. And here I am here today giving you this message. AA works. It is very important for us to be anonymous. We are anonymous, but we are not invisible. We are a fellowship known to the world. We are present in 180 countries, which is great because AA has been growing every day. So I'd like to thank on behalf of the World AA, this fellowship without borders. So thank you so much for coming here to listen to me and to listen to the other panel members, but especially me, what to hear what I had to say. Thank you again. 24 hours of sobriety and serenity. Thank you. Thank you very much, Maria. Now I'd like to give the floor to Paz P. Let's hear her testimony.
Muchas gracias. Muy buenas tardes. Gracias a la Asociación Panamericana de la Salud por darnos un espacio para compartir.
Thank you very, very much to Pajo for giving us this opportunity to share. I am Paz and I am an alcoholic and a member of Alcoholics Anonymous. I was in Mexico City and that's where I knew about Alcoholics Anonymous. I now live in the United States. I started to drink at age 14 and practically never stopped for the longest time. I immediately felt that I was addicted. I felt that. I felt the grip of alcohol on me and the need to continue drinking. And I couldn't understand fully why I acted as I did and why I drank as I did, but I did. And I got to AA in a way because my internist, my main doctor, had asked me at a particular point in time, well, how much do you drink? And because he was beginning to see some real damage in terms of my health. But I didn't go because of a doctor's referral, but because two people who were talking about AA struck me. And I thought, oh, wow, I know what they're talking about. And when my doctor asked me how I was doing, how much do I drink, he asked. Well, I thought that was normal. I had no idea that the amount of alcohol that I was downing was not normal. I had no idea what was normal or abnormal for a person who, in point of fact, wasn't normal to begin with, but I didn't know that. Now, over time, I can tell you, thanks to AA, Everything is much more transparent. I was able to have a very, very frank and candid conversation with the different health professionals that have helped me, because I finally understood that alcoholism is a disease, beginning with the fact that it didn't let me understand how much in its grip I actually found myself. I had no idea of the magnitude, of the seriousness of the problem, of the disease. And it was AA that helped me understand that. I had no idea either how gravely I had damaged my life, my family, and my work environment, not only because of how I was drinking, but of how I was behaving with people around me. Now, in Mexico City, I did get that message one day when there were men and women who were sharing with each other how they had stopped drinking. Boy, that stopped me short. I was absolutely intrigued and I wanted to know more, because what they were talking about was what I was living. And I understood that, and I wanted to know more. Now, when I came to the United States, I have to tell you that the cultural shock was incredible, because in the United States, the Hispanic culture is really dominated by men mainly, very few women. And to find oneself in a group of AA where most of the people there were men, you know what? It wasn't that easy. It was interesting to see, but I was struck by the fact that, unlike what had happened in Mexico City, where there were a heck of a lot of women in AA groups, that was not the case in AA in the US. And I tried to go every day, and the kind of disease that I was living and that I live meant that I wanted to go to an AA meeting daily. And even though, say, when every weekend came around, every Friday morning, I said, well, I'm not going to fall into this again. This weekend, I won't drink. Or that holiday, I'm not going to try it. I'm not even going to taste it. And I'm not even going to think it. And I kept saying, I can't drink. I can't drink. And yet, guess what? 3 or 4 hours later, that was then, and now was now. And before I knew it, I was yet again drinking. And by the way, this was not a promise that I had shared with people and that then they knew I had broken. I only said it to myself, but I knew I'd broken it. And then I understood when I began to have it shared with me that this is a program that is based on 12 steps that involves on servicing, on giving, on understanding that it's 24 hours, day by day, 24 hours, 1 hour at a time, and sometimes shorter time than that. But it's day by day. It wasn't forever, day by day. But the destructive behavior that I came to understand I was living wasn't only bad for me, for my health, because of the alcohol consumption flowing through my veins. It had to do with my family, with my friends, with my work relations. This is a disease that goes way beyond an individual body or mind. That's what I came to understand. And if I could just quickly touch on COVID, tell you a little bit how the COVID pandemic affected me, good or bad, I'll tell you. The pandemic started pushing people that were meeting in person to understand that they maybe couldn't do it. And so that is how we understood that, well, we couldn't stop meeting. That was clear. So we started meeting via Zoom. This has opened an enormous panorama where we have understood that we have been able to get in touch with people that probably weren't able to come to those AA meetings, maybe because maybe they came one time and they were all men and they said, no way, I'm speaking as a woman, or maybe they weren't able to go there for any number of other reasons. But Zoom, I'm here to tell you, has made the difference and has made it possible for us to share the solution that we have found. with others in a much more effective way, as far as I'm concerned. And so, as a result of this, I have been able to restore my family relations. I've been able to live in greater peace with my immediate family. I came here as a single person. I had hoped to get married, but guess what? My relationships, I should say, never really worked out. But once I was sober, I was able to find a partner, to have a long-term relationship, and as they say, get a life. And in my work, I can tell you that I have been able to work there for over 10 years. Then the program I was working in came to an end, and that was not happening, I will tell you, before. Economically, socially, personally, financially, and in every other respect, I'm hanging in there. And let me end by saying that at the end of the day, even though some groups are starting to meet again in person, because hey, we understand that face-to-face has its strength, and in AA, in every respect, there's something very strong meeting face-to-face. But guess what? The Zoom groups are also going strong, because numbers of people that are still meeting on Zoom have understood that it has its own benefits, ability to connect in other countries with other peoples. Maybe we have the same language in more ways than one. We share a disease. We are trying to share the solution. That's what I can tell you, dear friends. And thank you so very much for your kindness and listening to me. I'm Paz, I'm an alcoholic, and I'm here to help. Thank you.
Thank you very much. Excellent comments, and really very enriching, all of today's presentations, very touching. My final message, my conclusion is that there is not one single solution, but people must be aware of the existing alternatives, especially those that are close to them, and then find the one that will be the best and will fit each one's situation. Paola really did think about this and did contact the AA office precisely to make its resources available on the PAHO website. And Paola actually refers individuals to these services in each country, as well as other treatment resources every time it is possible to us to find them, and always free of charge. All of the resources that we publish or post on the PAHO page related to Paola, the tool, all of them were sought after based on this. And as Paz has just said, it is true that during COVID, we've seen this need to open up new opportunities wherever people were. And undoubtedly, to be present is very important. Human interaction is really important. However, there are other cities in the Americas, in Latin America, with no service at all. So the mere possibility of being able to have contact with a mentor online for support, or eventually even to create a local group, that might be a possible alternative, or maybe the only one when there are no such services nearby and because of the pandemic measures. Of course, those places that do not have AA groups yet. Of course, a lot to do. Still, Paola also asks about this, or questions rather, this social acceptance of alcohol. It does inform people on what is normal or not normal, as Maria has mentioned. It is important to know this because many people are not aware that they are drinking too much. So we are 3 minutes away from the end of our webinar. I saw that the questions were directly answered. But if you have any other comments, final comments, panels, members, please, we're open.
Se não há perguntas,
If
novamente,
there are no further questions, one thing that I really liked to hear is that your groups are anonymous but not invisible. And the goal of our program is to make problems and needs visible and to try to offer greater coverage and effective programs in all of America's countries. So again, thank you so much, all panelists. Thank you for being with us. Thank you for your availability, and we hope to go on collaborating in the future. The women's group helped us, sending us more than 100 questions on alcohol and health. These questions were used when we were programming Paola, for example. Very interesting. So it is always possible to contribute and to help each other. Thus, I'd like to close our webinar with our thank you to all.